Okay, so the question is, in a situation, in this case, post-prostatectomy where salvage radiation may be required, how would hip replacements bilaterally affect the targeting of the prostate? Certainly, first let's discuss the role of radiation after surgery. So there's a couple different roles of radiation. One is called salvage, as you know. In salvage radiation, the prostate's out. There was nothing under the microscope that looked suspicious in terms of margins or extension through the prostate.
I did get a positive margin.
Okay. The PSA goes to 0, and then over time, your PSA is slowly rising. So over the years, we've looked at that group of men and said, when is it best to act? When should we give the radiation? So we actually did a study out of Wayne State several years ago, and it looked at pre-radiation PSA of 1.0 and less, and showed that those men do the best of other subgroups of patients. A larger study came out shortly thereafter from Massachusetts General Hospital and other institutes in Boston and Massachusetts, and they even showed that a PSA less than 0.5 is more beneficial to patients than waiting for it to go higher up. So the bottom line from a lot of these studies is that the earlier the better. However, in the range that we're talking for you, the PSA is way, way, way too low to think about radiation at that time. Most of the time what we're seeing is 0.2, 0.3, 0.4 when we want to initiate radiation. So for you, we're talking 0.02.
Yes.
So
it's not an issue till 0.5. What did you say? Sorry.
Well, I wouldn't consider yours, especially with the super sensitive PSAs, I wouldn't consider yours elevated. Again, if you see it go to 0.1 and then 0.2 and then 0.3, then we're going to start considering radiation. To go from 0.06 to 0.08 to 0.09, even though it's rising, it's still at a level where it's probably, not pulling the alarms yet because it's too low, and although PSAs may be more accurate post-operatively because you don't have a prostate, it may not be accurate enough at that point to jump into radiation until we're starting to see it in higher levels. In terms of the actual delivery of radiation itself, we do it all on 3-dimensional planning. So it's CAT scan-based planning. What that allows us to do is target the prostate bed, or for someone with an intact prostate, target the prostate. And we put in avoidance structures for the bladder, the rectum, and the hips. So in designing the radiation, which basically goes around 360 degrees, but we determine from all those angles what angles are the best for the longest amount of time and the most intense to make this the safest treatment. So when somebody has a hip replacement, we spend extra time on the planning to make sure that we're avoiding the hips. So it's going to be more intense from the angles that don't go right through the hips. So in the older days of radiation, where we didn't have these sophisticated ways of designing and delivering radiation, you pretty much say one angle, one angle, one angle, one angle. So maybe 4 to 6 angles around. Now it's 360 degrees around, so we're better able to spare normal organs and consolidate the dose on the prostate. So the presence of the hip prosthesis may make it a little bit more challenging, but not from your standpoint. It just makes treatment planning a little bit more sophisticated. One of the